Appendix J, Protocol for Building a Milk Supply, Relactation-Induced Lactation. Immediately after giving birth to a baby, the complete placenta is delivered. When this is immediately followed by holding the baby skin to skin, the uninterrupted baby moves to the breast, familiarizes, self-attaches, and begins suckling. This optimal scenario will trigger a change in the milk cells from producing colostrum to producing newborn or transitional milk, and then within a week or so, only mature milk. Sometimes the process described above is not the one that was experienced. Perhaps the baby was admitted to a special care nursery, or the baby was unable to suckle. Perhaps the baby started to suckle, but continuing was difficult or impossible. Lactation was halted, and now, days, weeks, or years later, milk production is desired for this baby or another. Perhaps the person who wishes to lactate is not the person who gave birth. We can look at these counseling sessions in three ways. Building a milk supply while lactating, the need to increase the amount of milk produced in a person who is lactating. Relactation, the need to begin lactation after a pregnancy or after a lactation has been stopped, even days, weeks, months, or years later. Induced lactation, the need to begin the process of lactation for a person who has not been pregnant or given birth. Building a milk supply while lactating or for relactation. The need to build a milk supply or to relactate can result if breastfeeding gets off to a suboptimal start. For example, not breastfeeding frequently enough, expressing for weeks for a preemie, or in other cases of separation and expression. Stopping lactation and then wanting to start again. Overuse of a pacifier, smoking. Lactation suppressing medications such as decongestants containing pseudoephedrine and steroids have been taken or administered. There are physiological problems that are the underlying cause for poor milk supply, such as inadequate breast tissue, class 3 inverted nipples, postpartum hemorrhage with resulting pituitary insult, breast surgery or injury, abnormal levels of thyroid hormones. If and when these are corrected, milk supply can rebound. Retain placental fragments. Consider the potential for altering the conditions that contributed to the condition of poor or low, no milk supply when developing a plan to build the milk supply or relactating. A realistic assessment of the reason for the low milk supply should precede the planning phase. Ask yourself, is the reason for low milk supply modifiable, partially modifiable, or non-modifiable? If nursing was done on a schedule and too few times a day up to the point of assessment, perhaps a plan to increase the number of feedings will be enough. The situation is modifiable. If a pacifier is being used in place of nursing, the situation is modifiable. If cigarette smoking has depressed prolactin levels, the situation is modifiable. If lactation-suppressing medications have been used or administered, the situation is modifiable, if the medications can be replaced. If hyperthyroidism has been evaluated and thyroid function is now within normal limits due to medication, the situation is modifiable. The supply may increase with simple breastfeeding management. If there is inadequate milk-producing breast tissue due to breast development or after profound breast reduction, or there are 2 class 3 inverted nipples, the situation may be partially or non-modifiable. It may be physiologically impossible to increase the milk supply to meet the baby's total needs. Determine the goals from building a milk supply. Is the goal to exclusively breastfeed at the breast? To provide express milk via a supplemental feeding method? To breastfeed and supplement with bottles of formula or express milk? To collect milk to feed the baby away from the breast? Assess the current milk supply or transfer. By estimating how much milk is currently available by expression or transfer to the baby, it will be possible to monitor increase. If expressing milk only, ask that the volumes of as many expressions as possible be logged. If feeding at the breast, estimate milk transfer using the protocol in Appendix E. Estimate the baby's daily needs, Appendix F, and determine how much milk needs to be expressed or transferred to the baby while nursing. Estimate the amount that is being expressed, transferred, and subtract that from the amount the baby needs. Here's an example. The baby was born at 6 pounds and was not very active for nursing. Feedings were every 3 to 4 hours, and the baby weighs 5 pounds, 11 ounces at 2 weeks. There are no other known risks for low milk supply reported. The pediatric care provider has determined that the baby needs to catch up, meaning a need for 15.38 to 17.06 ounces per day. The baby is reported to be only feeding at the breast 8 times a day. Pre- and post-feeding weights indicate that the baby transfers 0.5 ounces on one breast and 1 ounce on the other. If this is typical, then the baby is receiving 1.5 times 8 equals 12 ounces. We estimate a need for milk volume to increase by 4 to 5 ounces a day. Note, the pediatric care provider should take the lead in determining the estimated need. So, as a doula, you're not assessing how much. You can give an approximation, but really this is the role of the pediatric medical provider. You have to take a step back because it's beyond our scope of practice, but this is a good to know thing that you can tell your families. Determine how the baby is being fed now: breast, cup, bottle, at breastfeeder, other. Consider available methods to increase milk supply. Is expression an available method of increasing milk collection or supply? Is the baby willing and able to nurse more times a day? Would the addition of an at breastfeeder increase breast stimulation and work to increase supply? Consider the nature of and delivery method for additional milk. Is the baby being fed formula? Could it be replaced ounce for ounce with expressed milk? Is safe donor milk available to the mother? CHMBANA and International Milk Banking Initiative in Appendix Y. Which supplementation methods will suit this family and also protect the future of breastfeeding? Appendix N. Make a plan for monitoring and follow-up. At the Center for Breastfeeding, we would encourage those with milk production problems to consider combining hand expression with pumping with a rental-grade double pumping system. We would work closely with the baby's pediatric care provider to monitor the baby's weight gain, and negotiate use of express or donor human milk as available to replace formula. When a substantial amount, 75 to 80% of the milk that is needed to make up the deficit can be expressed, we would again assess milk transfer, Appendix E. You might also consider having the baby weighed in the home with a digital scale accurate to 2 grams to monitor the baby's transfer. We often do this with premature babies who are discharged receiving half or more of the intake of formula so that it can be more accurately determine how much formula to use as a supplement after breastfeeding. We would recalculate needs as the baby grows. Induced lactation. Determine the goal for inducing lactation when there has been no prior pregnancy. The milk-producing cells differentiate and grow under the influence of the hormones of pregnancy, especially estrogen and progesterone. Even when those hormones are taken without a pregnancy, changes are encouraged in the milk cells. We recommend talking to a healthcare provider who is knowledgeable about induced lactation and about hormonal solutions that are appropriate in individual situations. Birth control pills are often prescribed for inducing lactation since they mimic pregnancy. The spacer or inactive pills that come the spacer or inactive pills that come in the pack are not used. The framework for this plan assumes that after months of taking the hormonal contraceptives, the milk cells will have developed and increased in number. Suddenly stopping the drugs and starting hand expression is akin to hormonal experience of delivering the placenta and beginning to breastfeed. Once the baby has been born, encourage frequent skin-to-skin contact, breast stimulation, milk expression, and use of an at-breast supplementer to deliver donor milk or formula to the infant to increase the potential for milk making. One question we are often asked is, will this work for me? And we can say in return, it's hard to know. Or even an early miscarriage may give the cells a boost in their development. Years of taking estrogen may make a difference in whether or not there will be milk or how much. Each situation is unique. We like to put the emphasis on the experience of closeness and bonding rather than how much milk is being produced, especially in the case of induced lactation. And that is the end of Appendix J.